Reminders to all the attendees, you may type in your questions regarding the lecture in the chat box and the speakers will gladly answer them for you. Or you may personally communicate them by sending a message to the email provided on the screen. We would also like to request everyone to answer the evaluation form after the last speaker of the session. Link will be seen in the chat box. Good evening. Let me introduce our speaker for tonight's simultaneous symposium. To speak to us about initiating mechanical ventilation in critical ill pediatric patients is the current training officer of the section of pediatric pulmonology of Philippine Heart Center. She is a fellow of the Philippine Pediatric Society, a fellow of the Philippine Academy of Pediatric Pulmonologists, and a fellow of the Philippine Society of Critical Care Medicine. She had her fellowship on pediatric pulmonology and critical care medicine at the Philippine Heart Center. Let us all welcome Dr. Charito de Los Santos.
Good evening. My lecture for tonight is very timely because of the increasing number of COVID cases in children, and the leading cause of their admission in the intensive care unit is respiratory failure. So it is very important for us to know the basic principles and the evidence-based guidelines of mechanical ventilation that will help us in the management of our critically ill pediatric patients. These are my objectives. The interaction between the ventilator and the child is strongly dependent on the mechanical properties of the respiratory system. During gas exchange, a pressure gradient is needed in order to drive the flow of gases between the airways and the alveoli. This is determined by the volume, compliance, resistance, and flow. Compliance is the stiffness or the distensibility of the lung and the chest wall. Resistance is the capacity of the air conducting system and the tissues to oppose the airflow. Time constant is a product of resistance and compliance. It determines the rate of change in the volume of a lung unit that is passively inflated or deflated. Now, what is the significance of the time constant? Lungs that have shorter time constant have decreased compliance, leading to incomplete inspiration and expiration. This may affect the tidal volume, the peak inspiratory pressure, and the mean airway pressure, leading to hypercapnia and hypoxemia. There are two important pressures that you have to be aware of. The peak inspiratory pressure, which is the pressure needed to fully inflate the lung during inspiration, and this is a measure of your airway resistance. Next is the plateau pressure, which is achieved at the end of full inspiration and is a measure of alveolar pressure and lung compliance. We now go to the different ventilator settings. The tidal volume is the amount of air that moves in and out of the lungs with each respiratory cycle. The target tidal volumes range between 5 to 8 ml per kilogram of the ideal body weight based on height rather than on the actual weight and depends on the disease severity. The respiratory rate or frequency is the number of breaths per minute. The positive end expiratory pressure is the airway pressure at the end of expiration. It is important in preventing airway closure or alveolar collapse and can improve oxygenation. Initial PEP settings of 5 to 8 centimeter water are commonly used in pediatrics. The required PEP depends largely on the disease processes. Initial fraction of inspired oxygen is set based on the patient's supplemental oxygen requirement prior to intubation and the overall assessment of the patient. It should be reduced to 60% or less as quickly as possible to avoid the risk of oxygen toxicity. Common target parameters also depend on the severity of the disease. Inspiratory time is the period of time over which the ventilator delivers a breath. Initial settings are age and rate dependent but may be adjusted based on the underlying disease of the patient. The expiratory time is determined by the set rate and inspiratory time, while the IE ratio refers to the ratio of inspiration to expiration, and the normal IE ratio is 1:2 or 1:3, but may be adjusted to 1:4 or greater in obstructive airway diseases. Flow rate controls how fast the tidal volume is delivered by the ventilator. The peak inspiratory flow rate can be set directly on the ventilator, or it can be calculated by the ventilator for a set tidal volume or pressure and the inspiratory time. And this is adjusted depending on the patient's inspiratory demands. Trigger is the mechanism that initiates the inspiratory phase of the ventilator. In pediatrics, airflow triggers are commonly used and the thresholds are adjusted for age. While in pressure trigger, threshold is set at -1 centimeter water. Time trigger can be used in patients without adequate spontaneous respiratory effort. On the other hand, cycling is the transition point from the inspiratory phase to the expiratory phase. We usually use time or flow cycling. In time cycling, the set threshold is after 3 to 5 seconds. Flow cycling is commonly set at 25% of the peak inspiratory flow rate. Ventilators are classified based on first the breath sequence, how the inflation is initiated, whether assist control, synchronous intermittent mandatory, or spontaneous ventilation. It is also based on the control variable, how the gas flow is controlled during the inflation, whether pressure or volume. And lastly, based on cycling, how the inflation is terminated either by flow or time. In assist control ventilation, all program breaths are delivered within a fixed inspiratory time. Each breath may be initiated by the patient or the ventilator, but once initiated, the ventilator will deliver the entire breath. This mode of ventilation is used in patients with little or no spontaneous respiratory effort. SIMV is the most common mode of ventilation used in pediatrics. It is a combination of mandatory and spontaneous breaths wherein the patient or the ventilator can initiate each supported breath. A set rate is selected and the ventilator will deliver these mandatory breaths each minute, regardless of the patient's respiratory efforts. Any breath taken by the patient above this rate will be unsupported. In the spontaneous ventilation, all breaths are patient-initiated and the ventilator augments the patient effort with pressure or volume as set by the clinician. Pressure support is the most common support mode used. The setting is based upon the effectiveness of the respiratory effort and the internal diameter of the endotracheal tube. In the volume-controlled ventilation, the tidal volume and the inspiratory flow rate are set on the ventilator. It cycles when the preset volume is delivered, and the pressures will be dependent on the compliance. In the pressure-controlled mode, the peak inspiratory pressure and the PEP are set on the ventilator. It cycles when the set volume or flow is reached, and the tidal volume is dependent on the lung compliance and the airway resistance. Trials in pediatrics have not shown any mode to be superior to another in improving the outcomes. So in selecting a ventilator strategy, the most important thing to remember is to use a volume or pressure that causes good visible chest rise and air entry on auscultation. So the principal indications of mechanical ventilation include hypoxemia, hypercapnia, and airway protection. Inadequate oxygenation or hypoxemia can be due to ventilation perfusion mismatch or intrapulmonary shunting. Oxygenation depends on the FiO2 and the mean airway pressure, which is determined by your PIP, PEP, IE ratio, and the flow rate. Increasing any of these parameters should raise the oxygenation in order to correct the hypoxemia. The Pediatric Acute Lung Injury Consensus Conference Group, or PALIC, recommends the use of the lung protective ventilation. This strategy uses low tidal volume with elevated PEP, and the goal is to avoid the ventilator-induced lung injuries. When using the volume control ventilation, you aim for a tidal volume of 3 to 6 ml per kilo for patients with poor lung compliance. In pressure controlled, the PIP should be maintained at less than or equal to 28 centimeter water. We use a minimum of 6 to 10 centimeter water of pressure support to achieve a target tidal volume of 4 to 8 ml per kilogram. PEP is initiated at 3 to 8 centimeter water depending on the disease severity and may be needed to be escalated with close monitoring. Now, if there is continued hypoxemia despite the increased FiO2, increasing PEP as high as 15 to 20 centimeter water may be required in order to maintain an adequate lung volume. But the inspiratory plateau pressure should be limited to 28 cm water. So the inspiratory time can also be increased to improve your oxygenation. The peak inspiratory pressure is also adjusted to target a tidal volume of 4 to 6 ml per kilogram with a maximum 10 ml per kilo. Higher PIP up to 30 to 40 centimeter water may be required for those with poor lung compliance. And to reduce the potential risks of oxygen toxicity, lower oxygenation targets may be acceptable in the critically ill patients. This strategy is known as your permissive hypoxemia that allows O2 saturation of 92 to 97% for mild PARDS and 88 to 92% for severe PARDS and the preterm infants. The use of low tidal volume in the lung protective ventilation can decrease the minute ventilation and lead to significant hypercapnia or respiratory acidosis. In these instances, another lung protective strategy, the permissive hypercapnia, may be applied wherein the partial pressures of carbon dioxide is allowed to rise by increasing the respiratory rate. However, this is contraindicated in intracranial and pulmonary hypertension and those with ventricular dysfunctions. Permissive hypercapnia should be considered for moderate to severe PARDS. Increased levels of PCO2 as high as 85 millimeters mercury are tolerated well by children as long as the pH is maintained above 7.2. The increase in PCO2 should be gradual, that is no more than 5 millimeter mercury per hour. Potential adverse effects include increased intracranial pressure and arrhythmias. Respiratory failure secondary to hypercarbia results from the inability to generate the adequate minute ventilation, which is the product of your tidal volume and your respiratory rate. Increase in the minute ventilation will facilitate CO2 elimination. Common causes of inadequate ventilation are ineffective respiration due to muscle weakness or fatigue, obstructive lung diseases like asthma and bronchiolitis. The management for ineffective respiration will be the same as for the airway protection and will be discussed later. So given the risk of complications, intubation in hypercarbia is indicated only in the presence of concomitant hypoxemia, altered mental status, increased work of breathing with concern for tiring, inability to protect the upper airway, and or respiratory arrest. Either pressure or volume control modes can be used. SIMV plus pressure support of 6 to 10 centimeter water is commonly favored to prevent respiratory muscle deconditioning. For spontaneously breathing patient, pressure support of more than 10 centimeter water may be used. Respiratory rate should be near or below physiologic for those with asthma, but in bronchiolitis, we use higher respiratory rates. We also use prolonged IE ratio to allow sufficient exhalation. The initial FiO2 of 100% is weaned until oxygen saturation of 90 to 92% is reached. Maximum inspiratory flow rate is 80 to 100 ml per minute for rapid delivery of breaths, facilitating prolongation of the exhalation time. PEP of at least 3 to 5 centimeter water should be given in order to address the added resistance from the endotracheal tube. And lastly, you keep your plateau pressures and the PIP low to reduce the risk of barotrauma. If there is persistent hypoxemia despite the maximal FiO2, consider atelectasis. And the PEP can be slowly increased at 1 to 2 centimeter water at a time. Now, if you are using volume-controlled ventilation and you need to give excessive pressures to achieve the tidal volume, you can switch to pressure control. And lastly, you have to ensure adequate oxygenation, but avoid excessive oxygen delivery. As regards the ventilator adjustments, the increase in RR should be kept near or below physiologic to prevent the breath stacking and dynamic hyperinflation. Adjust inspiratory time and the inspiratory flow rate to increase the IE ratio to permit longer exhalation time. Permissive hypercapnia is allowed since the aim is not normalization of the PCO2, but a pH of more than 7.2. If a patient is uncomfortable or agitated with resultant increased airway pressures, you can make adjustments in the ventilator to improve the synchrony. However, if the source of agitation is the permissive hypercapnia, sedation or neuromuscular blockade can help. Patients intubated for protection alone are those with no underlying lung disease. Again, both pressure or volume control can be utilized. Assist control or SIMV are used for patients with little or no respiratory effort. For patients with spontaneous respiratory effort, you can use SIMV plus pressure support or pressure support alone with a backup rate. If you are using volume-controlled ventilation, set tidal volume at less than 10 ml per kilogram of ideal body weight. And if pressure control is used, PIP is commonly set at 16 to 20 centimeter water and not to exceed 28 centimeter water. Start with PIP of 5 centimeter water to limit the atelectasis that frequently accompanies intubation, sedation, or supine positioning. FiO2 is initially set at less than 60% and win to maintain O2 saturation of 92 to 97%. The pressure support is set between 5 to 10 centimeter water and depends on the internal diameter of the endotracheal tube. This table shows the recommendations of the Pediatric Mechanical Ventilation Consensus Conference on invasive ventilation, monitoring, and target parameters, most of which were already discussed earlier. Common complications of mechanical ventilations are decreased cardiac output and hypotension, ventilator-induced lung injury, autopip, increased intracranial pressures, and ventilator-associated pneumonia. Autopip occurs in patients who required prolonged exhalation like asthma. This can lead to breath stacking, but it can be diagnosed by your expiratory port occlusion test or your manometry. Now, when autopip is diagnosed, the patient should be temporarily released from mechanical ventilation to allow for full expiration. And then the ventilator can be adjusted to increase the expiratory time by these maneuvers. Decrease the set tidal volume, increase the inspiratory flow rate, and reduce the respiratory rate. With regard to supportive measures, airway humidification is recommended, but routine installation of isotonic saline prior to suctioning is not. All children should be maintained with the head of the bed elevated to 30 to 45 degrees. Chest physiotherapy cannot be considered standard of care for airway clearance. Cuff endotracheal tubes can be used, but the cuff pressure should be less than or equal to 20 centimeter water. The dead space apparatus should be reduced and manual ventilation should be avoided to prevent the delivery of inappropriate pressure and volume. Cardiac monitor, blood pressure, and pulse oximetry monitoring are recommended. Obtain arterial blood gas 10 to 15 minutes after the institution of your mechanical ventilation. Check the expiratory volume to ensure that the set tidal volume is delivered. check for auto air leak, and monitor for auto PIP in patients with airway obstruction. Check peak inspiratory and plateau pressures. Assessment of these pressures can provide insight into the cause of the respiratory difficulty. Elevated PIP and plateau pressure may be caused by non-compliant lung, right mainstem intubation, pleural effusion, and ascites. Elevated PIP but normal plateau pressure suggests a resistance or obstruction to airflow and may be due to mucus plugging, bronchospasm, or asynchrony. This table shows the drugs commonly used in mechanical ventilation. But for patients with asthma or bronchiolitis, a ketamine infusion is preferable because it provides bronchodilation. When a child suddenly develops respiratory distress or hemodynamic instability while receiving mechanical ventilation, assess the airway, breathing, and circulation. Look for the immediate threats such as dislodged or obstructed ET tube, tension pneumothorax, or equipment failure. Reassess the need for reintubation. Look for the probable causes of the increased respiratory effort or evaluate the underlying disease. These are the different maneuvers to achieve the desired changes in the mean airway pressure, PO2, and the PCO2. The same ventilatory strategies apply in the specific patient population with some important considerations. For those with lung hypoplasia, the optimal tidal volume should be smaller than physiologic because of the lower lung volumes. Those with chronic neuromuscular diseases, you aim for preservation of the spontaneous breathing. For the chronically ventilated or those with congenital diseases, you have to evaluate the risk-benefit ratio. Use high PIP to stabilize the airways in children with trachea or bronchomalacia. For cardiac patients, assisted ventilation is preferred. Afterload may be affected in those with ventricular failures, so sufficient PIP should be used to maintain lung volume, and the titration of the ventilator settings should be carried out even more carefully. For patients with elevated intracranial pressure or traumatic head injury, target a normal pH and PCO2, but lower if there is evidence of impending brain herniation. In cardiogenic pulmonary edema, high PIP may decrease the venous return and resolve the pulmonary edema. In pulmonary hypertension, normal pH and PCO2 should be targeted. In patients with diabetic ketoacidosis and salicylate toxicity, the mechanical ventilation should be reserved for airway protection of those severely obtunded. The PCO2 before and after initiation of mechanical ventilation should be the same, and during intubation, avoid periods of apnea that can lead to CO2 accumulation, which can worsen the acidosis and the toxicity. Asynchrony or fighting the ventilator can occur with both controlled and patient-initiated modes. It can be caused by high respiratory rate, the use of uncuffed ET tubes, air leakages, and auto-PIP. You can minimize this asynchrony by increasing the trigger threshold, reducing air leaks in the circuit, increasing the respiratory drive, application of external PIP, or additional sedation. For the last part of my lecture, I will discuss the PEMVEC COVID-19 recommendations, but I will just focus on the practice recommendation for the invasively ventilated children. Intubation is recommended if there is no improvement with the first-line approach, like your CPAP, bilevel NIV, or high-flow nasal cannula within 60 to 90 minutes. Intubate with cuff ET. And once intubated, the panel recommends the lung protective strategy per PALIC recommendation, which uses low tidal volumes for poorly compliant respiratory conditions. Initial PEEP should be around 10 centimeter water, and further increase may be needed in more severe cases. When FiO2 to less than 60%, you maintain O2 saturation at 92 to 97%. However, for patients with severe disease, the minimal acceptable O2 saturation should be 88%. The panel recommends allowing for permissive hypercapnia. They also recommend the use of neuromuscular blocking agents in the first 24 to 48 hours for those with moderate to severe PARDS. Prone positioning can be considered in moderate to severe PARDS, and practices vary between 12 to 18 hours per day. Prolonged prone positioning more than 24 hours may be considered early in the disease. The panel also recommends the following escalating therapies for refractory hypoxemia: PEEP titration using the ARDS network PEP FiO2 grid, nitric oxide trial, high-frequency oscillatory ventilation, and lastly, consider ECMO if refractory hypoxemia persists despite all the measures used. For PEEP titration, you can use this ARDS network FiO2 PEP grid as guide. I would like to end my lecture with this message. A ventilator is designed to save lives, but if used incompetently, it can cause irreversible damage. These are my references. Lastly, I would like to thank all our frontliners who have been risking their lives and safety, especially the Pediapulmo Fellows of the Philippine Heart Center, for their dedication and care of all our patients in the critical care units. Thank you and stay safe.
Thank you, Dr. Charito de Los Santos, for sharing a very informative lecture. Once again, we welcome your questions and comments in the chat box. Our speakers will gladly answer them for you. Now, at this point, allow me to present the Certificate of Appreciation to Dr. Charito de Los Santos for being our speaker in the 12th Biennial Symposium, Exploring the New in Pulmonology, given this 16th day of September 2021, signed by Dr. Cesar Antonio Ligo, President of the PFL-HRD, Dr. Eileen Banson, Head of the Division of Pulmonary and Critical Care Medicine, and the members of the organizing committee.